This is a slide from the CDC showing influenza severity assessment by season and by age group. So on the left-hand column, you can see various flu seasons over the past couple of decades. And then you can see from age 0 to 17 years, 18 to 64, and age 65 or older. And of course, all ages combined is on the right-hand side. So you can see that from 2009 to 2010 season, flu season has been either moderate or low until it hit a high severity in 2014-2015 season, and then again in 2017 and 18, and then the last season 2024-2025 was also a high severity. Now you will see that what's missing in the left hand side is the season 2020-2021. That is when COVID started and we had a nationwide lockdown, and that season essentially we did not have any flu activity, so there is no data for that year simply because of lockdowns and physical distancing. There was not much flu activity going on. Now let's take a look at the composition of the flu vaccines. In general, the flu vaccines are either trivalent or quadrivalent. Trivalent means that there are 3 strains in the vaccine. Quadrivalent means 4 strains. And in general, we have 2 different sets of vaccines. The egg-based have slightly different strains in them compared to the cell-cultured and recombinant vaccines. So for 2025-26, you can see that the first strain is an influenza A H1N1. And you can see that the strains are slightly different between the 2 types of vaccine. The second strain, which has been updated for this season, in other words, strain 1 is actually the same as what was in the vaccine in the last 2 seasons. Whereas for strain 2, this is what was a mismatch in the previous flu season. So it has been updated to better match what's circulating. And that is a H3N2 influenza A. Strain 3 is a vectorial lineage of influenza B, and that has remained the same in the last 4 seasons. And we no longer, starting last season, we no longer have a quadrivalent because influenza B Yamagata lineage has pretty much been eradicated for a few years, so there is really no need for a 4th strain. So last season and the current season, we essentially, every vaccine on the market is a trivalent. Here are the recommendations from CDC's ACIP. So essentially, routine annual seasonal influenza immunization is recommended for all persons aged 6 months or older who do not have contraindications. And there is no preferential recommendation for any influenza products that's age appropriate. The only exception is for age 65 years or older, which we will discuss shortly. But essentially, whether it's live attenuated or inactivated vaccine, as long as it is an age appropriate, there is no preferential. You can choose any available vaccines. In general, it takes about 2 weeks for the body to develop immunity to the vaccine. So keep that in mind. And vaccination should be offered during September and October and continue through flu season as long as unexpired vaccine supplies last. Now for non-pregnant adults, early vaccination, for example, vaccines usually become available in July in the retail pharmacy world. So early vaccination in July and August should be avoided unless there is concern that later vaccination might not be possible. We will discuss recommendations in pregnant individuals specifically on a later slide. And COVID vaccines can be co-administered with influenza vaccine, so it does not affect efficacy or safety of either vaccine. And these are the available products in the US market. So essentially we have one formulation that's a live attenuated influenza vaccine, which is FluMist. Again, all of these are trivalent currently on the market. Of note, FluMist is only approved for age 2 years through 49. So anybody under the age of 2 years cannot get FluMist, and anyone 50 years or older currently based on FDA approval cannot get FluMist. Now, FluMist is not an injectable. It is, I will discuss this on another slide. It is an intranasal administration, and it is egg-based. So you will see that most of these vaccines are developed in eggs, and we have a couple that use different technology. So FluCellVax is a cell cultured, which essentially uses mammalian cells to replicate the vaccine virus, and FluBlock uses recombinant technology. Now, for inactivated influenza vaccines, the standard dose, which is recommended for most individuals under the age 65, you will see several formulations are available on the market. All of them are for age 6 months or older. FluCellVax, which is cell culture for age 6 months or older. FluBlock, which is a recombinant, it used to be approved for only adults age 18 years or older. This year it has been extended to age 9 years or older. FluAd has an adjuvant in it, so it actually has better immunogenicity, and because of that, this is specifically designed for elderly age 65 years and old, because as we get older, our response to vaccines may diminish, so this is designed for that. Alternatively, we have a high dose inactivated influenza vaccines such as Fluzone HD, again designed for age 65 years or older. Now, most of these, as I mentioned, are developed in eggs, which brings us to the question of egg allergy. What if the patient has egg allergy? Although not common, you may come across patients who have egg allergy. As I mentioned, majority of the influenza vaccine formulations are grown in eggs. Both cell culture grown and recombinant influenza vaccines are considered egg-free. The recombinant vaccine utilizes recombinant DNA technology to manufacture the vaccine, and the cell culture grown vaccine utilizes mammalian cells instead of eggs. So should we only give recombinant influenza vaccine to patients with egg allergy? Well, first, it's important to know that CDC recommends considering patient observation for 15 minutes after administration of any vaccine, not just the flu shot, and regardless of whether they have had allergies or not. Secondly, regardless of reaction to egg exposure, even if anaphylaxis, the recommendation is that all persons aged 6 months or older with egg allergy who do not have contraindications should receive any licensed and recommended influenza vaccine, including the egg-based vaccine. The bottom line is that egg allergy is not a contraindication to receiving egg-based influenza vaccine. Now, what if the patient had allergy to a previous influenza vaccine ingredients and not just egg allergy? We can consider 3 different groups. So one would be people with an allergy to egg-based vaccine. The second group would be people with allergy to cell-cultured vaccine. And last would be people with history of reaction to a recombinant vaccine. So in general, when the CDC says precaution when it comes to allergies, use should occur in an inpatient or outpatient medical setting under supervision of a provider who can recognize and manage a severe allergic reaction. And of course, vaccine components can be found in a package insert. So for the first group, those who have allergy to egg-based influenza vaccines, any egg-based vaccine, it's contraindicated for these patients. However, they may receive a non-egg-based vaccine, so either a cell-cultured and recombinant. Now, again, this has nothing to do with eggs. This has to do with allergy to an egg-based vaccine. Now, for the second group, who, if they had an allergy to a cell-cultured inactivated influenza vaccine, any egg-based is contraindicated as well as the cell culture vaccine. However, they may receive, cautiously a recombinant influenza vaccine. And of course, last group, if they had a history of allergy to recombinant, again, egg-based is contraindicated as well as recombinant influenza vaccine, but they may cautiously receive cell-cultured influenza vaccine. And of course, if it is unknown which influenza vaccine they had a reaction to, then an allergist can be consulted to figure out if it's okay for the patient to receive a vaccine. Now, what are vaccine considerations during pregnancy? So persons who are pregnant or postpartum should receive any inactivated influenza vaccine or recombinant influenza vaccine, as long as this is before or during the flu season, and can be given before pregnancy and during all trimesters of pregnancy, but in general, limited data during the first trimester. The live attenuated vaccine should not be used. It's actually contraindicated during pregnancy. And in general, there is less experience with more recently licensed inactivated influenza vaccines, such as all the quadrivalents that are available on the market and the cell cultured based vaccine. And there is limited data with recombinant influenza vaccine. Last, what if the patient is taking influenza antiviral medications? Now, administration of inactivated or recombinant is not affected by antiviral agents. However, if somebody is to take the live attenuated because that vaccine needs to replicate in the body, antiviral medications will affect the vaccine efficacy. And when it comes to our antiviral agents used for the flu, the half-life makes a difference. So, some of these, such as Pramivir and Baloxavir, have much longer half-life, whereas oseltamivir and zanamivir have shorter half-life. So in general, the live attenuated influenza vaccine will have reduced effectiveness if oseltamivir is taken within 2 days before and up to 14 days after. So in other words, if somebody is taking oseltamivir for an actual infection or for either prophylaxis or whatever reason, and they are to receive a live attenuated, they should wait 2 days after discontinuing oseltamivir to start vaccination. And then once vaccination is given, they should wait at least 14 days before they can receive, for whatever indication, another dose of oseltamivir. And the same concept applies to Pramivir and Baloxavir, but the timing is different. So for Pramivir, 5 days before and up to 14 days after. The 14 days is because it takes, on average 2 weeks for the vaccine to kick in. So once it's given, regardless of which one it is, you want to wait 14 days for the vaccine to replicate and mount a response. And then the other ones, the 2 days, 5 days, and 17 days, you essentially waiting for these drugs to be cleared from the body based on the half-life, and then give the vaccination. Now, what if the patient is elderly, and that's defined as age 65 years or older? So there are 3 preferential recommendations. So either the high dose inactivated influenza vaccine or the recombinant influenza vaccine, which essentially has a higher dose than the standard dose inactivated influenza vaccine, or an adjuvanted inactivated influenza vaccine. And of course, they do say that if none of these are available in the pharmacy, then any other age-appropriate influenza vaccine should be used. So any vaccine is better than no vaccine. So you don't want, in other words, if somebody's at the pharmacy and these 3 are not available, you do not want to, order it and have the patient come back, because there is a good chance that they may not come back. So any opportunity to vaccinate individuals is very important, because any vaccination is better than no vaccination. And the reason these 3 are preferred over others is that, for one, the high dose was studied against the standard dose, and these are specifically in the trivalent vaccines where they did a randomized controlled trial. And they found that the high dose was superior to the standard dose. Specifically, it had about 24% greater relative efficacy compared to the standard dose. And when it comes to recombinant, compared to the standard dose, again, recombinant has slightly higher dose in it. So in elderly, they also saw higher efficacy, so about 30% greater relative efficacy compared to the standard dose. And of course, the adjuvanted Fluad uses MF59 as an adjuvant to increase immunogenicity, which showed about 63% greater relative efficacy. Now for 2024-25 season, there are new recommendations for immunocompromised patients. So not only does the CDC continue to recommend to avoid live attenuated vaccines and prefer inactivated influenza vaccine and recombinant, but there's also recommendation that solid organ transplant recipients aged 18 to 64 who are receiving immunosuppressive medication regimens may receive either the high dose or adjuvanted as acceptable options. So remember, these two are only approved for age 65 and older. They're saying that although these patients are not 65 yet, you can consider them, but they make it clear that this is not a preference. So it's not that we prefer to give high dose and adjuvant, but you can consider it in order to potentially improve immunogenicity because these people's immune system is not as robust. Now let's discuss FluMist for self or caregiver administration. This is a new formulation of FluMist that was approved by FDA in September of 2024, and it is anticipated to be available for the first time in 2025-26 influenza season. And because this is a nasal spray, essentially people can administer it themselves without the need for a healthcare provider. So this is convenient, and people can order this online and it will be shipped to their house. It will remain cold during the shipping, and then once the patient receives it, this is a single dose in a pre-filled syringe. Now, it is important to note that half of the dose needs to go into each nostril, so there is a dose divider clip that essentially is halfway on the plunger. So it's important for people not to remove this until they have administered the first spray. So once they push this plunger, it will stop after administering half of the dose, and then and only then people should be instructed to remove the dose divider clip by simply pulling it to the side, and then they can proceed to administer the remainder of the dose into the second nostril. So this is a single dose, but 2 sprays, 1 in each nostril. That concludes this presentation.